All right, welcome back to the Nexus Podcast. Austin Allen, the Director of Solution Architecture at Airlock Digital, is my guest. And we're going to spend some time talking about healthcare cybersecurity and what hospitals are doing right and where they're struggling. So good to meet you. How you doing?
Pleasure. Thank you. Yeah, it's been a little chillier than expected here, but the crowds have been fantastic.
I know. I'm from Massachusetts, like we were talking about. Yeah. I think it's warmer at home than it is here.
It definitely is.
It's okay. How's the show going for you?
Excellent.
Yeah.
I think
busy.
I've barely stepped foot on the show floor. It's just been so many great conversations outside of it.
Yeah.
The partner ecosystem here is incredible.
Right. Yeah, I know that they still have the two expo halls, and it's just insanity in there. It's hundreds of vendors. And
monster trucks and puppies and goats. And
puppies?
Oh, yeah. There's a whole pen of puppies. There's a lot of
It's going to get people in there.
It would, yes.
So tell everybody a little bit about kind of your day-to-day and what your company does.
Sure. So Airlock Digital is focused on application control. We do that through operating system hardening. Really what we do is turn the endpoint into a deny by default model. So with the EDR, everything is allowed to run, and then the EDR tries to detect what's bad.
Yeah.
Our whole approach is the EDR is necessary in today's world. However, there's some fundamental things about locking down the system that we provide: living off the land attack, hardening the OS, legacy system protection. So just good gaps that systems need, and that's really what we focus on.
So your customers are beyond healthcare, you guys?
Very much. Yeah, healthcare is really any regulated industries are a really good target for us, but healthcare is very high on our list. Financial services is also really high up there.
Mm-hmm. So let's talk about healthcare for a little bit. Just bring me inside. Like, what's the reality that you're seeing inside of hospitals around connectivity? What's being connected? Why are they doing it? Should they be doing it?
Should they be doing it is always the fun part. You're right. There's the balance between what works at the hospital versus how much of a fine are you going to get hit with. Most hospitals know that if somebody wanted to come through and file enough HIPAA regulations, they'd probably find something wrong.
Right.
But it's always the balance of what do we need to do our jobs versus what is the fines worth versus, the public knowledge of kind of where the gaps are. The hospital industry is super interesting because the budgets, I think, have tightened a lot. Like, it's almost in the conversation for me of almost like education budgets, where it's like, hey, this is the budget. It is what it is. It doesn't matter what the requirement is. We either fit in this budget or we can't do it.
Yeah.
And with hospitals, it's even more complex because you've got a lot of legacy systems medical devices is the easy target, but a lot of those medical devices, the manufacturers just put out the updates whenever they want to. So you may have a vulnerability on a device that needs to talk to the nurse's station or other computers, and you go to the manufacturer and they say, we're going to fix it in 9 months, and until then, it's up to you.
You're exposed, yeah. And, it's probably the same story within factories and everything, but the dynamic with hospitals is obviously so much different because it's patient care, and that's their core competency. And, I'm going to share a password if it means, keeping this person alive or safe.
Yeah, I always get nervous when I see sticky notes on monitors.
Yeah.
I'm assuming it's medical related, but I'm sure there are some passwords still out there. But to your point, like if you can't have security without constraint, and with constraint, there's only so much you can squeeze before people find ways around that, right? Mm-hmm. So finding that balance is not just about the technology; it's about the culture that's set at the hospital, and that doesn't start from the IT and security team. That starts from the leadership and the executive team downwards.
And what's your experience in terms of security culture? Is it happening, or is it just like we need more resources, we need more people, more expertise? What's the reality there?
It really has become about patient care. So, in the beginning, it was brand reputation damage. Well, the studies have shown that most companies that are publicly traded that have a breach, they bounce back to their pre-breach stock price or higher within 90 days. So it's not really about the financial anymore of the reputation. It's about the downtime and outage. And what does that do to patient care, to the ER system? It's really about patient care now and lives, which is where it always should have been. But now there's a real scrutiny on that. Mm-hmm. I think the boards for hospitals understand that, and really cyber insurance has become really difficult for hospitals to get, and the expense is so high. There's a lot of hospitals in particular, or even rural hospitals, that are self-insuring themselves. They just set $1 of money aside and say, if something happens, we're just going to pay it ourselves. We have no cyber insurance to cover us.
Wow. Really? It's just that expensive that
it's
hard
that expensive.
To get. And I know, insurance companies have these questionnaires that are hundreds of questions and dozens of pages long, and, if you don't meet all those check boxes, it's not going to happen anyway.
Sure. And most of these hospitals never will. So they have
Right.
to try to find some type of compensating controller or establish or say that they've done that. And the reality of it is ransomware, for example, is a big hot topic. And a third of the ransoms happen where a leading EDR is deployed. It's not necessarily the EDR's fault. In some cases, it's being bypassed. But
Yeah.
in most cases, it's a misconfiguration.
Right.
And there's no check for that. The insurance check is, do you have EDR? Right?
Right.
Do you have network segmentation? Do you have this? And you can say yes, but there's levels of how you configure those things that make you successful, and those aren't ever checked in those really questionnaires.
Yeah, they haven't gone that level down yet. How are hospitals doing in terms of kind of like bringing, not equating cybersecurity with patient care, but kind of just making that link that, if systems aren't reachable or records aren't available, imaging systems are ransomed, whatever, it's going to impact negatively. Are they doing a good job of kind of communicating that message? Or
They did. So in the COVID era, there was actually a lot of threat actors that said, hey, we understand the world's in a difficult time. We're not going to target, healthcare. That lasted maybe 9 months. And then they were like, we want money. Right. So we're going to go back to that. But in that period, a lot of folks in healthcare took the opportunity to train their staff on how to use paper and pen, how to fill out charts manually. There's a whole generation of people that have never had to do that outside of an iPad.
Right.
So some took the opportunity to do that, and some didn't, and the ones that didn't ended up making the news.
Mm-hmm.
And if both hospitals got breached, the one that was able to maintain keeping their ER open is the one that avoided being in the public eye versus the one that had to shut the ER down and divert ambulances is the one that caught a lot of scrutiny and a lot of flack.
Yeah. You don't want to be the one to divert patients.
You do not.
Yeah. How much is regulation and compliance governing cybersecurity programs inside of hospitals?
Huge.
And does that make sense?
Yeah, huge. So our company was founded in Australia, and the cyber regulations are actually more strict than what we have in the U.S. We have a lot more frameworks. They have a lot more mandated regulations. And it's very clear the differences, like even HIPAA itself. I think there's a new major iteration that's on the floor this year, but there's only been 2 ever major iterations to HIPAA since it came out 20-something years ago now. That's insane.
Yeah.
I mean,
that's 20 lifetimes in security and tech.
In cyber in particular,
right.
Every 3 years, a third of your knowledge has been updated. So you think about that, in 9 years, everything that you knew has become completely different. Mm-hmm. And we're talking over 20 years of regulation.
Right.
So there's no way we're keeping up with it. And so it's really, what are you doing to keep up with the minimum amount of regulations versus what are you doing to being secure? And I'm sure you've heard this, but it's the adage of compliance is not necessarily security.
Right. Do they welcome that kind of guidance, though? At least there's kind of like a North Star to shoot for?
Yeah. Again, in Australia, they're very, very direct with this guidance. In the U.S., we don't like being told what to do as much. We like to rebel a little bit. So I think in the highly regulated areas of like healthcare in particular, when it comes to patient safety, I think there is a want to get more direct guidance versus maybe the financial sector. A lot of the regulations cost them money, and so they see it as a cost versus a necessity. In healthcare, I think there really is a focus now on, okay, we get it, we need this, and in a lot of cases, particularly in the medical device sector, these vulnerabilities have no patch, and so it leaves the hospitals left with the liability because these vendors who create these tools and put out the software, they're not held accountable for patching and being secure by default with what they're putting into the hospitals. It puts an unfair burden really on the healthcare system to figure out how to control and secure that.
Mm-hmm. All right, that's a question I had later on in my outline here, but I think we should be talking more about the medical device manufacturers and the OEMs. It's like it's all on the hospital right now.
Yeah, there's no liability legally for these OEMs and these manufacturers to do anything about some of the security breaches.
Yeah.
It's still 20-year-old thinking of, I'm building OT technology to work, I'm not building it to be secure. And the reality is we needed to do both now. And we've needed that for a very long time, but there's been no financial incentive for these manufacturers to put security into the product.
Yeah.
So we have to, I think, legislate that a little bit and actually put some financial dollars behind, hey, if you don't do this, it's actually going to be least valuable to you as a company. You're going to lose more money having to fix this than you would actually being secure by design whenever you're implementing.
Mm-hmm.
Until that happens, there's no financial incentive for these manufacturers because it's not their reputation of loss of life, it's the hospitals.
Right.
Or the healthcare organization or the doctor's office or the dentist or whoever.
You mentioned the secure by design, secure by default. They're all great initiatives, but stuff's already out the door. It's kind of hard to apply that going, you can apply it going forward, but not in reverse.
That's part of why I came to Airlock Digital. We didn't do anything unique. Like having a deny by default model for system security is not a magical legacy thinking. It's actually something that's been around for a very long time, but it's been a process problem to implement, not a people problem or a technology problem. And so what we focused on is the process of, I've got a legacy system. I can't deploy a full EDR because it'll break the system. It's in a VLAN that has medical devices, so I can't ping and I can't scan or I'll break those systems. What can I put on that system to either create a compensating control or something to actually have a deny model?
Yeah.
And the answer for most folks has been microsegmentation or some type of VLANing. That's, in some cases, just not feasible. I may need this device to talk to the nurse's station. How do I segment this nurse's station off from this device? But then now this nurse's station has to be on a different VLAN. I can't talk to my other systems. There's too much complexity for IT admins to keep up with, and it's just not feasible in some areas. So that's a big use case for what we do, is deploy an extremely lightweight agent. It doesn't scan, it doesn't ping, it doesn't need a reboot. We can see what's on the system now. You say, hey, the system is operating in the way that it's supposed to.
Yeah.
And then you hit enforce. And from there, no new code, no new application, nothing can be installed, nothing can be adjusted on that system. It just runs the way that it's designed to run. And so now if I'm a threat actor and I somehow get access to that system, I can't deploy any of my tools. I can't run any foreign code. I can't do anything to it.
Right.
So it becomes a question of, is this thing vulnerable? Yes. Is there any ability to compromise it? No. And so now I have an actual compensating control on a legacy piece of system that I didn't have to take my business down for, that I can actually have a hard preventative measure and say that to the auditors or my insurance. Being proactive with that level of security is going to be financially in the best interest of healthcare organizations, not just from avoiding the breach and the cost of that, but to go back to cyber insurance and try to negotiate lower premiums.
Yeah. Is it hard to sell into hospitals? Like, as a security company, you can't be the disruptor.
Yeah.
So, I mean, I'm sure that's like the big kind of starting point of the conversation.
The hardest part is, are you a known entity, right? I'm willing to take more of a risk on, the old adage of nobody ever got fired for hiring IBM.
Sure.
We are unknown in the U.S. market. In Australia, we've been around for 12 years. But in the U.S. market, we're a little more unknown. So for us, it is more challenging. But just generically for security, absolutely, it's difficult to sell security into hospitals. It's easier if you're already established, but normally that comes from your firewall vendors, who then branch out into some other type of tool, or the EDR, who has 50 other features. But again, the problem in medical in particular, are there are devices that are super sensitive. If you ping it, if you scan it, it breaks it. And most of the new technology and the AI data and all the new stuff we're adding on has made these applications and tools extremely heavy. They do a lot of things on your network. They create a lot of noise, and those legacy systems can't support that. So it removes a lot of those from the equation, and then hospitals are stuck trying to figure out, what does that compensating control look like? And that's really where we come in and provide that easy button versus trying to micro-segment your entire network.
Why is it breaking? Is it a compatibility issue, or is it just kind of the legacy part of it?
Yeah, two things. One is the compatibility, right? So if I have a device and it can't handle a lot of network traffic, and I've got something that's constantly pinging that network, it will break the device. The second is just from a hardware perspective. So again, back to the OEMs, like, they've designed the hardware at the minimum spec to run just what that thing was designed to do. It was never designed to have something added on to it. And so if I'm running some type of legacy system and it's running XP Service Pack 2, and I've got 25 megs of RAM on the whole thing, like, there's no room there for that for security, right? You're going to take the whole thing down.
Yeah. So to go back to the connected devices, is there like a business pressure inside the hospitals to kind of connect this devices? You can treat more patients, do more surgeries, whatever it is. What's driving connectivity?
Yeah, it's no security without constraint. So that squeeze, you want to create a posture of security and think security first, and yet if you squeeze too much, folks will just try to bypass you and go around you. And so the interconnectedness is, I as a nurse or I as a doctor want to be able to pull up records at any computer that I work in on any floor that I work on. Versus, should I be able to pull the ER records unless I'm in the surgical room, or should I be able to pull it in the copy and printer room, right? Do I need to be on a certain VLAN, or can I be on that VLAN?
Yeah.
Even IoT, like we all think medical devices, but even just printers and stuff, I mean, they have vulnerabilities too.
Yeah.
If you're not segmenting them off, like how do I from
it's
my
a way in the network.
Right. How do I from my nurse's station access all these patient records, but then still have the ability to securely print, because that printer now has talking to my computer that has the EHR records. Or where do those records even store? That gets into a whole nother conversation. So the interconnectedness is required for the speed at which hospitals need to move for patient care.
Yeah.
And yet it opens up more liability and risk.
How do you characterize the legacy software problem in hospitals? Like, are you seeing like commonalities among, some of the software that's being used, or just paint a picture?
The interesting thing about, I don't think it's hit quite yet, but AI in particular being used for code, we're seeing the same code used over and over again. In the way that we see medical devices, that's actually quite true. And they didn't use AI to do it. They used actual programmers.
Sure.
But a lot of times when they come out with a new device, they copy and paste code from an old device and then just add some new stuff to it and then sell it as a new medical device. But really, there's a ton of legacy code in there. So you may have an updated device, an insulin pump, and it may have now the ability to connect to the network, and the nurse can control it and monitor it from the computer. Number one, that's a whole different way of liability now when you have interconnected medical devices. But number two, it looks fancy, but the underlying code is actually extremely old code that's been highly effective. But again, back then there was no thought of security. It was, how do I make this work, and how do I make it work consistently? There was no thought of how do I make it secure. So by continuing in that medical device realm, you're actually inheriting a lot of legacy code that can be exploited.
Yeah. So you're inheriting the vulnerabilities that come with that old code.
Absolutely.
Wow. And so, and why can't hospitals do anything about it? Is it just a matter of, like, whatever it is it runs well and I can't touch it, shouldn't touch it?
That's part of it.
Yeah.
The ability to, you may not have a choice in the way the insulin pump is vulnerable. You do have a choice on how a threat actor could get to that insulin pump to begin with, because they're not going to start there. They're going to start somewhere that's internet facing and then move from that machine to other machines, right? And the whole point of EDR and why it evolved from AV was EDR was supposed to have behavioral detection, signature detections, lateral movement. It was more than just check a list and is it on the bad list? No, then let it go.
Yeah.
It's a lot more than that now. And EDR has done a fantastic job of making the threat actor attack chains really lengthy and more complex. However, a lot of these attacks are happening because there's system security that was never turned off. So EDR is most commonly bypassed by living off the land attacks. And living off the land attacks are nothing more than using the system tools that were already baked into the OS there now. So the EDR thinks that this is normal because it's part of the normal system it was installed on.
Yeah.
And yet 5 attack chains or 5 cycles in there later, they've used 3 different Windows utilities that you never use but are enabled still to then exfil the data or to get access and move. So our whole approach is AI and ML and all these things within the EDR have a fantastic place in the ecosystem of endpoint security. But there's a fundamental hardening of the operating system and removing unused features that you don't have that dramatically reduces the ability for threat actors to move in the environment or even get a foothold. And we're overlooking that fundamental security in lieu of the fancy tools that everybody recognizes and advertises. Because when we go to our bosses, it's a lot easier to say, hey, I have this fancy tool that every hospital down the road uses. Yeah. Versus, hey, I implemented this fundamental security. You won't know it works until it blocks something, but it's going to block everything that tries that.
Yeah. And so are there parts of the network or devices where EDR just can't be installed, just doesn't support an agent, or will break something? What kind of gap is that exposing?
A lot. Yeah. I mean, absolutely. And frankly, the devices that are most vulnerable are the ones that can't run a full EDR. They don't have the they don't have the hardware. They don't have the capability to support scanning or pinging. They may not be able to reboot without having downtime, which comes with a cost. And some of these legacy systems, right, like they've been running for 2 years, 3 years. You don't touch them. Like if they're working, you don't touch them. And so to even put anything new on there is a huge undertaking in the approval process, et cetera. We had one healthcare client in particular. It wasn't even medical device related. It was system badge. So they had a really legacy system that was managing the entire physical access controls for the hospital entirely. And that project to replace all the physical badge systems and remove that vulnerable legacy server was in the millions. It was extremely expensive because they have to re-architect the whole building to get all that new access. We're preventing any foreign execution on that legacy server and any vulnerability execution for fractions of the cost. Mm-hmm. And not only that, but it buys them not only more years of not having to replace the whole system, but now they can build a proper budget and plan for it and actually do a proper migration without having to cold cut it, without worrying about the fines that are going to come down from the government.
Right. You brought up vulnerabilities, like how complicated is vulnerability management, patch management inside a hospital. And like, okay, there's a new CVE. It applies to my environment. It's fairly critical. What happens? Because it's not like another enterprise where you can just kind of test it and roll it out.
Yeah, I mean, so doing, not just exposure management, but like vulnerability management, you're never going to be at 100%. Like you're always going to have something, and so you always have to look at the CVs, like you mentioned. Look at the grade, look at what you have, make a determination, and start patching based on what's most critical. With that being said, you have really two buckets in hospitals. You've got the systems that the nurses and doctors and everybody's using, the laptops, desktops, whatever. But then you've got this whole OT device, medical device sector. The systems you have a say in and you have control over. The medical devices, you don't. We hit on that earlier. Like the manufacturer says this is how it runs. You have no ability to change this code whatsoever. We're not going to patch it for 9 months, 12 months, 18 months, whatever. It's your problem now. And that's where you have to find those compensating controls.
Yeah.
It's already hard enough to do endpoint security where you're trying to keep up with vulnerabilities. It's even borderline impossible for hospitals to do anything about those vulnerabilities from the devices they're buying.
And what's that? There's no standardized time frame for a patch or a fix to be delivered from the OEM. I mean, I know it's got to go to the FDA for approval, et cetera, but
yeah, that approval process takes a while, but there's not a mandate to these OEMs to hold them accountable. Like not even just for putting security by design in place, but to also patch and repair vulnerabilities that may exist regardless of CVE. There's not only direct mandate, but there's not even a high enough financial incentive for them to get a move on and actually accomplish it. Which again, if that's going to be the case, you don't do it by just saying, hey, you need to do it. You do it by financially incentivizing them against what could happen if they don't.
Right.
So we have to be stronger in the U.S. about those types of regulations when it comes to lives. A lot of sectors it's about money, but in healthcare it's about lives. If we're not really strict and direct with what we expect to happen, there's been too many hospitals in the news that we've all seen, and some named large healthcare organizations, that get hit with ransomware. Nobody can fill prescriptions now because of it.
Right.
They paid the ransomware or pay the ransomware, still don't get the decryptor code, are told to pay again, and the entire time, small businesses that rely on them are shutting down. Prescriptions are not getting filled. Critical medicine isn't being
just
filled.
In the middle waiting,
They're just in the middle waiting.
And so just to go back to kind of that discussion we started before of like, we're asking everything of the hospitals and need to, look more at the manufacturers. What can they do? Are their hands tied at all, given the FDA's kind of oversight on vulnerabilities, for example? And
yeah. So, sorry, to be clear, it's from the hospital side or the manufacturer side?
From the manufacturer side.
Okay.
Yeah.
So from the manufacturer side, secure by design. Like, test your code, not just for functionality, test it for vulnerability, because there's some just low-hanging fruit that's getting through.
Yeah.
Number two, I know it's cheaper to continue to build on legacy code, but we have to move off of that. We've gone through even just Windows alone, regardless of Linux, which is what a lot of those devices run on. Windows alone, Windows 10, which feels like it just came out yesterday to me, is end of life this year.
It's end of life, yeah.
Right? And 11 has some problems, even with the most recent patch.
Right.
So to tell organizations you have no choice but only one version of Windows is actually supported is wild.
Yeah.
I mean, there's a speed that they're moving at that the industry is having a hard time keeping up with.
Mm-hmm.
And that's just in healthcare. And frankly, there's a lot of big organizations outside of healthcare where, they're spending millions and millions of dollars just replacing laptops that are end of life.
Yeah.
And the hospital, they may not even have that money. So they have to find some type of compensating control to be able to put in place for that. So from a manufacturer perspective, if I'm a healthcare organization, I'm going to my manufacturer, and I know there's really only a few that you can talk to that make what you need to make. But I'm trying to hold them accountable and saying, look, I'm willing to pay more up front for these devices if over the long run I will spend less because they're more secure, I have to replace stuff less, I have to put less compensating controls in, I pay less in HIPAA fines. I have yet to see a facility that would not be fined in some way by HIPAA. I've never seen one that's absolutely perfect.
Right.
So put that pressure financially, and again, the incentive, it's all financial incentive for the manufacturers. Say, I'm willing to pay more if you're willing to be secure by design. Yeah. Right? And then they have to prove it over time, but we have to start putting money either away, taking them away from the manufacturers, or putting more in their pocket to incentivize them to do the actual security we want up front.
Mm-hmm. All right, so before we wrap up, I want to talk about ransomware. I feel remiss if we don't in a hospital healthcare cybersecurity conversation. Just, is that kind of like the only threat you hear from healthcare customers is that they're concerned about? I mean, obviously there's more to it, but how dominant is the ransomware conversation when you get into an environment?
Yeah, ransomware is still number one for sure. I mean, I think data theft was extremely important for a very long time. It still is. Yeah. But the studies have shown not only how much, I think it's 1 in 3 Americans now or more have their healthcare information already compromised. But even the bounce back of financial damage from reputation isn't severe now. People are desensitized to this stuff. So it's really that downtime that matters the most. Like, that is the currency now, is downtime. And ransomware is a key contributor to the downtime.
Sure.
That's the one that'll cripple you from being able to operate. Again, EDRs are fantastic, but the configuration that's required is a little complex. You got to have some skills. And there are ways to bypass it even when it is fully in enforcement. So understanding that the bypass isn't coming from the EDR's inability to detect threats that you would expect. It comes from the EDR not detecting things that are already in the environment that you haven't turned off and locked down. Yeah. So, like, the number one thing for healthcare organizations is reduce your attack surface, and you don't do that by doing a whole bunch of configuration tool sets, engagements. You do it by simple, practical, deny, not just scan detect, but an actual hard preventative measure. Yeah. So VLANing stuff is a part of preventative measure of having one device talk to another. And for systems, it's similar for operating system hardening. Mm-hmm. Reduce the stuff on the OS that is not allowed to run in the environment, and you will significantly reduce your ability for ransomware actors to drop their own payloads in. Yeah. It's one thing for them to be able to get access. It's another thing for them to be able to bring their own tools. You don't get ransomed by them getting access. You get ransomed by them bringing their own tools. Right. So much complexity. I mean, every industry, touts their own complexity, but I have a hard time thinking anybody's more complex in healthcare right now. All right. Austin, thank you so much for coming on the podcast. Really appreciate it. It's been great. Pleasure. Thank you for your time. Appreciate it.